Okay, I think last time we stopped at the high flow. So high flow is another mode of respiratory support. So remember we have microflow, whereas the flow is 0.01 to 0.5, and some people say up to 0.9. That's we call it module. This is the only part of the ventilation when the flow is from 0.05, and some people say from 0.09 till 2, and some people um, say till 4, it's the normal flow. So we have microflow, low flow, the microflow from from 0.01 to 0.09, and the low flow from 0.1 to 0.5, and some people say to 0.9. That's low flow. The only flow that does not need humidification and blending is the microflow. And usually we use it for home therapy and home oxygenation. So usually we give 100 with the flow somewhere between 0.01 to 0.09. From 0.1 to 0.5, and some people say to 0.9, this is called low flow. And from 1, and some people say from 0.06 till 2, and some people say till 4, they call it normal flow, just flow oxygen. After 4, usually we start CPAP until we reach 16 in infant and 16 in pediatric and 8 in infant. We usually use CPAP. After that, we use something called high flow. So high flow is the flow that we give above the CPAP. So when we give high flow, the principle are heated, humidified, and blended. Blending means the flow comes from the air and the oxygen percentage as we need. And there are many ways to do the flow. There are ready-made, closed high flow, such as vapotherm, comfort flow, and optiflow. And there are just a blender, so without machine. So just a humidifier and blender. A humidifier and blender, that's all. So this is the vapotherm. This is the vapotherm. And you can see that it has some features such as alarm, such as humidification, temperature, the amount of flow, the amount of oxygenation. So it gives you exactly what you are doing. And you can see this is an example of high flow on a vapotherm. So this is the vapotherm. This is our vapotherm being used on infant. We have the comfort flow. So again, you see that the machine is here, the humidifier, and you can see also the blender and the panel that show you the measurement, and you can see the nasal prong and the humidifier. There is another one called OptiFlow, so not much difference from that. So we use high flow in respiratory distress, and when we need a pressure more than CPAP, and when the patient big enough to fight the CPAP, because so when you give CPAP, some babies will fight the CPAP. So if we cannot give CPAP and the patient is more than 35 weeks, the high flow is not advised in patient with less than 35 weeks. We give high flow. Okay, so it should be humidified, heated, and blended. It's the tolerance in term infant and children of high flow is better than CPAP, and it decreases the respiratory rate, the work of breathing, and it shows better oxygenation. So we can use it with premature infant with RDS, infant with bronchiolitis, adult with hypoxemic respiratory failure. So you see, hypoxemic, there is no ventilatory problem. So high flow cannot ventilate. When we say ventilate, means we cannot wash CO2. So remember, high flow is only used for oxygenation. Any question here? Very important to ask question if you didn't understand. Questions? Any question? Anything? Did you understand?
Yes, I will.
Okay. So it's indicated in adult without hypercarbia. Whenever there has hypercarbia, CO2 is high, we cannot use. So high flow oxygen therapy by nasal prong is a reasonable alternative to standard therapy of oxygen, just give oxygen by mask and CPAP. If there is hypercarbia and we want to use non-invasive ventilation, then CPAP is a better choice because it gives you pressure and mean that cause ventilation. And it's seen that when we use CPAP, we can minimize the use for intubation. Use of high nasal cannula is not advisable in premature babies less than 35 weeks, but some they are using it. So it's a little bit controversial. Mask is a very good option to deliver oxygen. So it's a very good oxygen delivery system, but the patient has to breathe by his or her own. The mask can fit the patient nose and mouth, and it can be secured around the head by elastic strap. There are various sizes, and we have to choose the size by putting one edge of the cushion of the mask at the tip of the chin, and then roll it over the mouth and the nose until the other end reached at the bridge of the nose. So that's how we measure the size of the mask. And sometimes it's very difficult to use in very anxious and uncooperative crying child, especially when strap it on the face. When we use mask, there is always risk of aspiration because the child can vomit. The
Sorry,
characteristic of the mask.
I have a
Go ahead.
question.
Go ahead.
What difference between hypercapnia and hypercarbia? What difference?
Hypercarbia and hyper what?
Hypercapnia.
Hypercapnia and hyper?
Well, yes.
Hypercapnia and hypercarbia.
Carbia, yes.
Oh, same.
Same.
They are same. Hypercapnia, hypercarbia. I mean, I guess hypercapnia is CO2 is high on the monitor. Hypercarbia is CO2 high on the gas. I think that's the difference.
Okay.
So I think hypercapnia is capnography. Nobody used it. I don't know how you, but hypercarbia is when the CO2 is high. I think they are the same.
Okay, thank you, Doctor.
Okay. So the characteristic of the mask, the fit of the mask, and presence or absence of reservoir determine how much oxygen are delivered to the patient. Type can be simple mask, so a mask that is transparent. There are knobs on either side, and it's connected to the oxygen one flow. Sometimes if there is a gauge at the bottom of the mask where it's connected to the oxygen supply, and this can move and change the flow, we call it Venturi. So it's a simple mask, but it has multiple flow through a knob that we can dial to change the flow. There is partial rebreathing, which means one side of the holes are closed, or there is valve that we can close and open. So simple mask is you rebreathe. So if it's only one side, it's called partial rebreathing, which means when you breathe out, you will take the same breath back because there are partial closure of the holes on the either side of the mask. Non-rebreathing, all the holes are closed. The oxy mask, the oxygen mask, there is kind of designed in a way that direct the oxygen toward the mouth and the nose. What are the benefit of the mask? We can give various concentration of oxygen in one device. And we can avoid CO2 by preventing the rebreathing. That's the benefit of simple mask. The masks are different type. It can be designed like in a triangular shape. It can have a cushion. It can be without cushion. The cushion can be water inflated. Maybe can be inflated by air. It can have additional port for delivery of medications. Okay, so this mask is made to give oxygen and to avoid respiratory failure as much as we can. And the whole purpose is to avoid intubation or invasive ventilation. So you can see here simple mask, but different type of the flow gauge. And it's a different color, and each color give you different flow and therefore give you different oxygen concentration. You can see that it also has a reservoir here, and you can see the oxygen port delivery, and here you can see that these are opening is the rebreathing. And you can see that the end at the bridge of the nose and this end at the tip of the chin. So the multi-flow is like a Venturi, but at a different flow. While the Venturi is only one flow that you can dial. So you can see this is Venturi, but this is a different fixed flow that you can replace it with Keller to replace the flow and give different flow and therefore give different oxygenation. And it can provide somewhere between 35 to 50% of oxygen. This depends on the respiratory rate and whether the mask is fitting or not. Question about simple mask? So it's transparent, it has a flow, it has two openings, it's like a triangular shape, it should fit, and it delivers oxygen to the nose and to the mouth. And sometimes it has a flow that we can dial, it's called Venturi, and sometimes we have multiple flow. Okay, the flow of the oxygen usually somewhere between 6 to 10 liter per minute. Question about simple mask?
I have just a question. In Venturi mask, the air in the room also will enter, and with the mask with the oxygen?
The Venturi is talking about this area that connect the mask to the oxygen source. And then you can dial. So once you change the flow, you change the concentration of the oxygen. Okay, so that's what Venturi is. The simple mask with a connection with the port of the oxygen that can be, the flow can be changed. Or we can use unchangeable connection or port, but different flow. So it's called multiple flow. They're same, but this one is one that we change the flow, and this one is we replace each one by its color. So it only change the flow, and once you change the flow, because it's connected to the oxygen without blender, therefore it will give you the percentage of oxygen change according to the flow. Did I answer the question, or am I misunderstand your question?
I understand what you said right now, but my question is, with oxygen, the patient any will receive also air and in the room.
No, there is no blending here.
Hmm.
Masks are not blended. This is only oxygen delivery system. There is no flow, there is no blend here. This is only temporary. This is only for the beginning. This is once you decide what you should do to the patient. So if you need blending, it has to be nasal cannula, CPAP or high flow. That's the only way we blend. And if it's microflow, you cannot blend. You understand?
Yes.
Yeah, no blending here. So usually the simple masks are plastic mask. Some might have reservoir. The exhaled gas escapes from the opening on each side, the exhalation ports. Once your baby start to breathe in, the room air enter and mix with oxygen, and that's why decrease the oxygen supply to the patient. And if we want to prevent the rebreathing of the room air, you have to give the flow more than 5 or it's 6 to 10. And that's why, because the flow high, it prevent the room air from entering the mask through the exhalation side ports. Clear? Questions?
دكتور
Yes.
عفوا دكتور بس one question يعني we can't use face mask without Venture or
No, you can
according
use
to
it. You can
order.
use the symbol. Yeah, you can use it like mask and it will have fixed flow. Okay, you cannot change the flow and you cannot change the percentage. So Venturi is a simple mask, but you can change the flow. Once you change the flow, you will change the oxygen concentration. Or if you want to change the flow, but you don't have Venturi, like a dial, like a knob, you can dial it, like مثل الفرارة تقدر تغيريه، من تغيريه تتغير الفلو.
Okay.
If you don't have, you can change. You can use different ports, and each port has a color, and each color has a flow, and each flow will have a percentage of oxygen. So all are simple masks. But the difference is you have one flow, or you have dialed flow, or you have various flow ports.
Okay. Thank you. تمام.
Okay, so if you want to prevent the rebreathing, you just give flow more than 5, or as we said, 6 to 10. So it's usually very helpful for patient need a little amount of oxygen. If you need more oxygen, then you have to use nasal prong. We don't know how much you are giving oxygen when you use the mask, so it's unreliable. Then we have partial rebreathing mask. So partial rebreathing mask is a simple mask with a reservoir. And because they have reservoir, then the percentage of oxygen, remember the simple mask delivers somewhere between 30 to 50. So this delivers a little bit more, 60, 50 to 60. And the flow, you remember the simple mask, the flow was somewhere between 6 to 10. The flow is 10 to 12. And because the flow is high and there is a reservoir, so the oxygen delivered to the patient is taken from predominantly fresh air coming through the oxygen or the and from the reservoir. The room air through the exhalation port are very small amount. The reservoir is mostly rich with oxygen, but sometimes there is some of the exhalation gas. The early exhaled air flow into reservoir from the respiratory dead space, and respiratory is from the nose, from the mouth, from the nose, nasopharynx, from the upper airway. And because the air in the lung are in the alveoli where the gas exchange, and therefore the air in the dead space is not yet exchanged. So once the patient exhale, breathe out, that air in the dead space will move to the reservoir. And the remaining air that was in the alveoli will go out because the reservoir is full. And once we breathe in, the air will come from the reservoir and from fresh air, and therefore will have minimum CO2. So that's the good news, that it has minimum CO2 because the air in the upper airway not involved in the gas exchange, and therefore there is no oxygen, CO2 moved from the blood, like the air in the alveoli. So the exchange in the alveoli, while in the upper airway there is no CO2 because there is no exchange. And once the baby breathes out, this will go to the reservoir. Once the reservoir is full, then the air that coming from the alveoli, which is after the dead space, will move out. And therefore, the air in the reservoir has minimum CO2. Most of the time, we use the partial non-rebreathing, usually when we transport the baby. Any question? The amount of oxygen that we're delivering in partial rebreathing, we can depend on, not like the simple mask. It can be diluted by the raw air because there are side exhalation ports, but not as obvious as simple mask. The rebreathing mask is mask with reservoir, but either the opening of the exhalation port either is closed or there is mask to control them. And these valves allow the air to go out, but never allow the air to go in. And the flow of the non-rebreathing mask is a little bit higher. If you remember, simple mask between 6 and 10, and the partial rebreathing is between 10 and 12, while the non-rebreathing mask, the flow is somewhere between 10 to 15. It needs very good seal and can give you very high oxygen. Remember, the simple mask give us somewhere between 30 to 50, and partial rebreathing give us between 50 to 60, while this can give up to 100%. Okay? Questions? The beauty of the non-rebreathing mask, if the oxygen is closed or decreased or kinked, still the patient can receive air or oxygen from the port, which is one side port. There is always a one-way valve, another one-way valve at the gate between the mask and the reservoir. It prevents the flow of exhaled gas from the patient to the reservoir, and therefore it prevents the mixed CO2 gas or air to go to the reservoir, and therefore didn't allow the reservoir to give always fresh air and fresh oxygen. This is example of the non-rebreathing mask, and you can see that there is one-way valve on the side. There is also another one-way valve at the junction of the reservoir and the mask. We call it entertainment valve. And you can see also there is oxygen tube supply. You can see the strap. Okay. And you can see the reservoir, and the reservoir here are closed reservoir. Any question? Remember, all masks are used in spontaneously breathing baby. The enclosure systems, we used to use it, but now is very limited. An example of the closure system is tent and hoods. Have you guys seen the tent? Have you ever seen the tent? Are you old enough that you have seen the tent before?
No, I don't see.
Yeah. So the tent is like a plastic house over the bed of the patient, and there is oxygen inside it, and the patient is inside that. It's like, example is like when we use the mosquito tent. So when you go campaign and you sleep outside, you have a tent and you sleep inside it to prevent the mosquito from coming in. Okay, so that's what we call a tent. Okay, and we can humidify the oxygen and the air, and we also can change the temperature. Both of them are very noisy, and both of them limit the access to the patient. So this is an example of the hood. This is a face hood. Okay, we rarely ever use it right now. This is the whole body tent. You can see the tent. It's covered the whole body. We can also provide oxygen with self-inflation bag, if you guys remember the self-inflation bag. So it's composed of the mask or the face mask, and the mask should cover from the tip of the chin to the bridge of the nose. You can see the cushion and the valve that inflate the cushion, and the cushion can be inflated by air or by oxygen. And you can see that the pressure relief valve or the pop-up valve, and the benefit of this valve is whenever you press or you squeeze the bag to inflate and there is extra, you're very anxious, the baby is dying. So to prevent, there will be release. If you give more than a certain amount, this valve will relieve you. This is oxygen source here, and this is the reservoir. So it's a self-inflation, mean that when you squeeze and then you release your hand, it will be reinflate by itself, and therefore it does not need flow to reinflate, and therefore you can use it during transport, and you don't need a source of flow to use it. Okay, any question about self-inflation bags? And self-inflation bag also can provide oxygen, but at the same time, it can do ventilation, can wash CO2. But that's why we use it, what we call it hand positive pressure ventilation or hand ventilation. Questions? Flow inflation bag is very important, but it needs flow. And this is the bag. And in this bag, you can hold it by a finger, and there is maybe a valve, or it's maybe open, and you have to hold it by hand, and it might be closed. And you can see the gauge here to determine how much you are, and then you can inflate. So it needs good seal, otherwise it will not inflate, and it needs flow. It can be oxygen flow, or it can be blended, but usually it's only oxygen flow. And therefore it needs, if the valve is break, it will not be inflated. If there is no flow, it will not be inflated. And if there is no good seal, it will not be inflated. And because it need 100 airtight sealed, then it can provide up to 100% oxygenation. However, it will not work if there is a break or there is no flow. Clear? Any question? Do you want me to stop here or continue?
Doctor, about
Continue.
last slide.
You want to continue?
Sorry, Doctor, but about last slide, I didn't understand how we
You
connect
didn't-
this. Yes,
So
flow
you
inflating
connect
bag.
here
How
to the
we connect?
oxygen source. You connect this to the
How
oxygen
connect?
source.
Okay. How we connect
And
to the
then
patient?
there's mask in here. You put a mask,
Okay.
and then through the mask you connect. This should be inflated. Okay, so you'll give 100% oxygen even without bagging. Once you start bagging, you can do ventilation. So you can provide 100% oxygen through the flow inflation bag. And if you start to squeeze the bag, you can do ventilation in addition to the oxygen supply.
Okay.
Okay, so this mask can give you oxygen supply, but at the same time, like the self-inflation bag, can give you ventilation. Both, they can give you oxygen and ventilation. However, this need a flow, and therefore it only use at the patient with the wall, or there is oxygen and air flow source, and that's why they call it anesthesia bag.
Okay.
Okay,
Okay.
is that clear, or you need like more explanation?
It's clear. Thank you.
Okay,
I
now
found
we'll move to non-invasive ventilation. So when we say ventilation, because previously we were talking about oxygen supply, but some of the oxygen supply systems can provide ventilation, such as flow inflation bag and self-inflation. Non-invasive ventilation is we support the respiratory system with oxygen, but with ventilation too. That means we blow out oxygen, we remove oxygen, but without ETT. So that's what we call it non-invasive ventilation. Okay? And non-invasive ventilation, okay, somebody is texting. So non-invasive are usually two types. There is CPAP, or positive continuous airway pressure. So when we say continuous, mean it gives you the same pressure during inhalation and exhalation. When we say positive, mean above atmospheric pressure. When we say airway, we mean the airway above the thoracic inlet, from the nose to the thoracic inlet. So that's the meaning of continuous positive airway pressure, CPAP. Clear? Any question about CPAP? So it's continuous, means same pressure during exhalation and inhalation. It's positive because it's above the atmospheric pressure, and the pressure is going to the airway. That's why it's called continuous positive airway pressure. Clear?
It's clear, doctor, but I think if we stop here, it's better and discuss something about tomorrow session.
Yeah. So let me finish this slide. I will stop.
Tamam,
So
thank you.
bilevel positive airway pressure mean you have two different pressure, not only one pressure, not continuous. So during respiratory cycle, you'd provide two types of pressure. You provide a pressure during inspiration, different from pressure during expiration. But both of them are above atmospheric pressure. That's why they call it positive. That's why we call it BiPAP. Or some people call it advanced CPAP. Or some people call it PSI-PAP. So sigh mean sigh. تاخد deep breath, sigh, you تشهق. That's called sigh. So some people call it PSI-PAP. Some people call it advanced CPAP. Some people call it BiPAP. And some people, for the first one, the CPAP, they call it plain CPAP. So we have a plain CPAP and we have advanced CPAP or bilevel CPAP or BiPAP. And CPAP, as we said, it provides oxygenation, but at the same time, it offers gas exchange. I mean, removing CO2. Okay, and let's stop here.